Thank you for joining this PCPCC webinar, Women's Health Across the Lifespan. Today you will hear from experts about the challenges and opportunities to bring diversity and voice with respect to delivering primary care that really meets the specific and important needs of women. I'm Julie Shills. I'm Senior Director for Health Innovations at Mathematica, and along with Rob Durbin from Merck, we serve as an executive member liaison to the PCPCC board. Mathematica is proud to be an executive member of PCPCC. We have benefited from PCPCC serving as a convener for the collective, bringing many voices to the area of primary care, the webinars, the annual conference, Surface Connections, and emerging policy and practice. Just this month, PCPCC held a special policy committee event in which we had the opportunity to hear from program leaders in the Division of Advanced Primary Care at the Center for Medicare and Medicaid Innovations. You might know them as CMMI. And they shared with us the directions for CPC Plus, a primary care initiative. So if you are interested in membership with PCPCC, please contact any member of the PCPCC team. An exciting webinar that's coming up is on March 21st. PCPCC will hold a webinar on dental integration in primary care, and on April 15th, the webinar will feature Dr. Sachin Jain, head of CareMore, and Dr. Gaurav Dayal, president of New Markets for ChenMed. Really exciting conversations with two unique programs working in the space of primary care and Medicare Advantage. In May, PCPCC will host a webinar on the emergence of AI in primary care. All of these registrations for all the webinars will be open soon, so check out the PCPCC website in the upcoming days for more information. And just because it's never too soon to plan, the PCPCC's annual conference is in Washington, D.C. this year and will be held November 4th and 5th. So mark your calendar, block it off, because it is well worth attending. Before I introduce our panelists for today, it's a really exciting presentation. The recording and the slides will be made available. We will have Q&A after the presentations. Please type your questions in the chat function, and I, along with the PCPCC staff, will surface those questions during the Q&A. So with that, I will introduce our panelists. Our first panelist is Katie Martin. She's Vice President for Health Policy and Programs at the National Partnership for Women and Families. She leads the organization's policy and advocacy efforts to support a healthcare system with universal access to high-quality, affordable, patient, family-centered care. We also have Nancy Lee, who is on the board of directors for the Black Women's Health Imperative. Dr. Lee is also a private consultant in Washington, D.C., with more than 30 years of experience in public health practice and policy. From 2011 to 2016, Dr. Lee was the Deputy Assistant for Secretary of Women's Health and the Director of the Office on Women's Health at the U.S. Department of Health and Human Services. Finally, we have Meredith Yinger, who is a policy analyst at the American College of Obstetricians and Gynecologists, otherwise known as ACOG. She handles value-based payment, delivery model reform, and other system transformation opportunities for ACOG. So with that, I will turn it over to Katie, who is our first panelist.
Great. Thank you so much, Julie. It's a real pleasure to be here. As Julie mentioned, my name is Katie Martin. I'm with the National Partnership for Women and Families. For a little bit of background about the National Partnership, we are a nonprofit, nonpartisan advocacy group dedicated to promoting equity and economic security for women and families. So what I wanted to talk a little bit about today was just the unique perspective that women bring to conversations about health and health policy. Based on our role as decision makers and caregivers, as the frontline healthcare workers, and as the majority of Medicare, Medicaid, and marketplace enrollees. This doesn't mean that other folks don't have valuable experiences to bring to the table, but rather that women just see the healthcare system a little bit differently, that the prism through which we look is a little bit different. Just as brief background, women make 80% of all healthcare decisions and are responsible for nearly 2/3 of caregiving in the U.S. There are nearly 3 times as many women and men in the healthcare workforce, and we are the majority, as I said, of Medicare, Medicaid, and Marketplace enrollees. And this just gives us a unique vantage point from which we view health and health policy. So to start, I wanted to talk about the importance of insurance coverage to women and their families. Not dissimilar from other populations, uninsured women find it harder to get care they need. They are less likely to be able to afford to see a doctor, less likely to use preventive services, and more likely to delay care because of cost. And the second point here is just underscoring the role of insurance in that equation. Women with lower incomes but without health insurance are less likely to have a personal doctor than women with lower incomes but who have health insurance. This next slide talks a little bit about the financial and health effects of our role, of women's role as caregivers. Women who are caregivers are 2.5 times more likely to live in poverty. Women who spend over 9 hours per week caring for an ill or disabled spouse are twice as likely to have heart disease. And caregiving causes a change in the work situation in nearly 60% of caregivers. Despite the outsized role that women play in health and health policy, our voices are too frequently ignored. Only 65% of women report fully trusting their physicians. Nearly half of women are labeled, quote, chronic complainers. There are myriad examples of ways that women's pain isn't taken seriously. In one study, women who were admitted with abdominal pain were forced to wait 16 minutes longer before receiving a pain reliever than men. There's also a study I didn't include here that found that women who present in pain are more likely to be prescribed a sedative than a pain reliever. And then the last point here is that women's health accounts for only 4% of overall funding for research and development for healthcare products and services. Because of, well, I don't really know because of why, but we also know that women are less likely to be diagnosed correctly, either because of the way that disease presents, heart attack being a really well-known example, but also because of the conditions that women have. Autoimmune disorders is a good example. Those are difficult to diagnose, but also pain diagnoses where pain is a primary symptom. So endometriosis is a good example of that. So in not taking women's concerns seriously, I wanted to highlight this story about Serena Williams. I don't know how many of you are tennis fans or Vogue subscribers, but Serena Williams gave birth about a year ago. And in the course of her birth, or following birth of her child, she experienced shortness of breath. Serena Williams has a history of blood clots and immediately assumed that it was a pulmonary embolism. She stepped out of her room to talk to a clinician because she didn't want her mother to worry, found the nearest nurse, and told her between gasps exactly what she thought she needed: a CT scan with contrast and IV heparin. She used those words. The nurse thought that her pain medicine might be making her confused, but Serena insisted. Eventually, a doctor came in and did an ultrasound of her legs and found no clot there. And Serena said, "Why are you doing that? I told you what I need. I need the CT scan and heparin right away." And sure enough, she got the scan and there were small blood clots in her lungs, so they started the drip. And at the end, she said, "Listen to Dr. Williams." I highlight this because if Serena Williams is having a hard time having her concerns taken seriously, it portends a difficult future for all women, particularly women of color. The other reason I wanted to share this story is because it begins to highlight issues and disparities in maternal health. And this is a role that's obviously unique to women. So I want to spend just a couple minutes here. One, highlighting for folks that a baby is born every 8 seconds in the US. I should have been setting a timer, but at least 3 or 4 have been born since I've been talking. Pregnancy, childbirth, and newborns make up the vast majority of, I shouldn't say vast majority, the vast plurality of hospital stays in the US. And yet the U.S. has the highest maternal mortality rate among developed countries and one of the few countries where that rate is going up. And even worse, we have this abysmal disparity between Black women and white women, with Black women experiencing a maternal mortality rate that is 3 to 4 times as high as white women. I also wanted to talk a little bit about mental health and the unique experience of women dealing with mental health diagnoses. In 2017, depression and anxiety were twice as common in women than men, but women have a tendency to believe that depression is just a normal part of aging. There's also, of course, pregnancy and postpartum related depression, and there has been some research showing that gender-based expectations associated with balancing work and family tend to cause women to delay accessing the care that they need. So as a national partnership, our policy priorities to try to bring the voice of women to these discussions are to advance health equity, to try to minimize and ideally reduce disparities between women of color and white women and between women and men, to reduce the financial burden of healthcare for all women and families, to improve maternal health outcomes, both by reducing the disparities and just changing the way we think about and deliver our maternity care, and then creating an infrastructure within the healthcare system to listen to women and to begin to take their concerns more seriously. And I think there are 2 angles to this. One is just recognizing that that women are really actively engaged in maneuvering their way through the healthcare system, and therefore they're good people to ask for input and feedback, and also that there's something at play, and I won't speculate about what it is, that is leading their concerns to be taken less seriously, and that's an issue that we need to address to improve health outcomes in the country. I think with that, I will wrap up. Look forward to Q&A at the end, and with that, I'll turn it back to Julie.
Great. And Dr. Lee, I think we will turn it over to you.
Thank you. So I'm very grateful to the PCPCC for asking the Black Women's Health Imperative to participate in this webinar. For 35 years, the Black Women's Health Imperative has been the only national organization solely dedicated to the health and wellness of the nation's 21 million Black women and girls. BWHI focuses on policy at the local, state, and national level, wellness, to focus on health rather than illness, HIV prevention, research translation, reproductive justice. And we've provided some publications for BWHI on the PCPCC website for your download. Black women face many health disparities. 80% are overweight or obese, higher than women of other races. They have a 42% higher mortality rate from breast cancer. They have 15% more cortisol, the stress hormone, in their blood at any point in time. And they have higher prevalence of heart disease, diabetes, hypertension, and depression than women of other races. Researcher Arlene Geronimus in 1992 established a causal relationship between experiences of racial discrimination and poor health outcomes. She coined a term, which I find very interesting, weathering, to describe how Black women age faster than white women because of the chronic stress and those higher cortisol levels that I already mentioned. For example, Black and white women given the same high-fat diet, Black women gain more weight and gain it faster. If given the same low-fat diet, Black women lose less weight, and lose it more slowly. Research has shown that provider beliefs about Black people are linked to racial disparities in health and health care. Various cultural stereotypes influence how information about an individual is processed. Robust research indicates that gender stereotypes may produce substandard care for all women, including Black women, and Katie just gave you some excellent examples of these problems. These stereotypes lead to unintended biases in decision-making, which have been called implicit bias. And I think some of the examples that Katie mentioned are exactly what's going on. When a Black woman perceives this bias, it may alter her behavior in ways that reduce her trust, her adherence, and her return for follow-up, and thus contribute to the disparities in her care. Research has also shown that providers' implicit bias affects their delivery of care. For example, a survey of physicians indicated that they believed that Black women don't experience pain as severely as white women, who are already having trouble with getting their pain believed as well. Other studies demonstrated that Black women were less likely to get pain medications that were indicated clinically. Providers need to understand this and consider it as a part of patient care. Providers should be trained to recognize their own biases and learn strategies to prevent these biases from influencing the care they deliver. I don't want to go into it, but there's now some well-validated instruments for looking at implicit bias. And this can be a start. It's apparently been a very effective way to get anybody, including healthcare providers, to recognize their own implicit biases. BWHI has just received a grant to develop an implicit bias curriculum for providers covering the area of women's sexual health. I want to delve deeper into a couple of these disparities that illustrate unconscious bias and the toll of systemic racism on Black women. Here's a major one. Black women account for 13% of the U.S. female population, but 64% of all new HIV infections. The vast majority of these women, these Black women, 91%, get their HIV infection through the heterosexual contact. For almost all the rest, it's through IV drug use. This map shows where the HIV infections are highest for all U.S. women. The darker the color, the higher the rate. But remember, 65% of these women are Black women. Areas with the highest rates are the District of Columbia, Maryland, New York, and Florida. Primary care providers have a critical role preventing HIV in women. They can provide pre-exposure prophylaxis, or PrEP, to women at risk. Trials have shown a 67% reduction in HIV transmission in heterosexual couples, and it's even higher with high compliance to the regimen. But doctors are cautious about PrEP for women. It's been prescribed primarily for gay men. There is no HIV risk assessment tool for women, and current treatment protocols do not consider the lived experience of Black women, which leads to erroneous judgments about their health behavior. Here are two more examples of implicit bias to add to what we've already discussed with Katie and my examples. A study of physicians suggested that they held beliefs that Black women weren't as susceptible to HIV and that PrEP wouldn't be as effective in Black women. Another study revealed medical students were less willing to prescribe PrEP because they believed Black women taking PrEP would be more likely than white women to engage in risky sexual behavior on PrEP. We know that Black women are unaware of PrEP. There have been no ad campaigns targeting Black women or their providers, despite the fact that the majority of women who are HIV positive are Black women. Who's a candidate for PrEP? Women with multiple partners who frequently come in with a new STD. Anyone whose sexual partner is HIV positive, and IV drug users who share needles. For many providers, getting this risk history takes time and sensitivity. You can't just do it with a checklist before they come in to see you in the office. Training and education are needed for healthcare practitioners, including sexual history taking and routine HIV risk assessments. The training should also include the details of the PrEP regimen and how to communicate it to women. Katie Martin has already talked about the crisis in maternal mortality and severe morbidity that we're facing in the U.S. I want to talk about it a bit more since it is striking Black mothers particularly hard. Nationally, Black women have 3 times a higher rate of maternal mortality as compared with white women. Just as a matter of fact, in New York City, it's 12 times higher. And I don't want to leave out American Indian and Alaska Native women, because as you see from this chart, they also have a substantially higher rate of maternal death. About 680 women die each year from pregnancy-associated causes in the U.S. While death is the worst outcome, CDC is also tracking something much more common, severe maternal morbidity, which includes transfusions, heart attacks, embolisms, and hysterectomies. Why is there such a high rate of maternal mortality for Black women? We know some reasons. Certainly, a chronic illness and overall health play a role. Obesity and hypertension, risk factors for pregnancy complications, are higher among Black women. But the social determinants of health listed on this slide are certainly important. These are systemic and arise from centuries of oppression and racism. The Black Women's Health Study demonstrated a causal relationship between the stressors of racial discrimination and maternal and infant mortality and uterine fibroids. And as expected, implicit bias also plays an important role. Katie already told you the example of Serena Williams. Shalon Irving, a CDC epidemiologist from where I spent 25 years of my life, died last year from pregnancy-related hypertension after complaining for 2 weeks. These are anecdotes, of course, but the bias has been supported by research. We already know strategies to reduce maternal mortality and severe morbidity. California has seen a significant decrease in maternal deaths. Much of this was done by adopting the recommendations from the California Maternal Quality Care Collaborative to reduce hemorrhage and complications from preeclampsia and embolism that occur during hospitalization. California now has the lowest maternal mortality rate in the country. Despite this good news from California, Black women didn't improve as much as white women in their rate of maternal mortality. To date, there have been no studies on interventions specifically on Black maternal mortality. The home visitation program in North Carolina is promising and has shown reductions in postpartum morbidity and mortality among Black women. We need more of these. Results from an illuminating study came out of New York. Black women were more likely to give birth in hospitals that have the highest rates of severe maternal morbidity. 65% of white women versus 23% of Black women gave birth in the safest hospitals. We must improve care in hospitals that disproportionately serve Black women. Let us not forget that the standard of care that is applied to Black women in clinical practice is based on a body of evidence that did not include them in its development. This means that their lived experiences, health behaviors, and even biologic responses that have been shaped by centuries of oppression are not part of the standards of clinical practice we all follow. Clearly, we need more research, but we also need to examine how providers, physicians, nurses, dentists, pharmacists, etc., are trained and include implicit bias training in their curricula. This will also help all women, I think. Finally, if we want to develop policies that include a focus on equity, we should tie reimbursement to equity in outcomes for provider practices and hospitals. Thanks.
Thank you, Dr. Lee. And Meredith, we'll turn it over to you.
Thanks, Julie. Hi, everyone. My name is Meredith. I'm a health policy analyst here at ACOG. ACOG is the professional membership association for over 58,000 obstetrician gynecologists, both nationwide and around the world. I'm going to be discussing the role of both primary care and women's health providers in addressing some of the unique needs that both Katie and Dr. Lee outlined that women face. So first, I'll kind of talk about two areas where people are familiar with OBGYN's involvement, and the first is the well woman visit. So both Katie and Nancy emphasized throughout this webinar that women's health is not just reproductive health, and the well woman visit is a good example of that. So OBGYNs actually use the well woman visit to do much more than just provide reproductive and sexual health services. Evidence shows us that about 44% of women actually use their OBGYNs and other women's health care providers as their primary care provider. So they use that opportunity to provide immunizations, mental health screenings, substance use screenings, exercise, lifestyle, and tobacco cessation counseling, along with some of the services you're probably more familiar with in this space, like breast and cervical cancer screenings, STI testing, family planning counseling, etc. Another area that, again, is probably where you think of seeing OBGYNs and other women's health providers are in the perinatal care space. So during this period, OBGYNs and other women's health providers provide a range of services, and they kind of have a unique opportunity to provide preventive and primary care services along with their obstetric care services, and they can also connect women to primary care providers and other providers they may need during pregnancy. Many women don't seek regular medical care before they become pregnant, or they use pregnancy as an opportunity to really improve their health. So OBGYNs can, again, provide counseling on a range of lifestyle choices, the importance of nutrition. They can prescribe pre-exposure prophylaxis or PrEP, administer various immunizations, and also transition women to a primary care provider during the postpartum period. Next, I'm going to talk about how primary care providers can address women's health needs across the lifespan using a team-based care approach. So the first population I'm going to talk about is the adolescent and pediatric population. OBGYNs and other women's health providers can work with primary care physicians, pediatricians, et cetera, to better address the needs of adolescent girls, postpartum women, and their children. So many OBGYNs would like to work with primary care physicians, nurse practitioners, and other providers to better serve the primary care needs of adolescent patients. At the same time, a lot of primary care providers may be looking to better address comprehensive counseling and education services to adolescents around sexual and reproductive health, family planning, and other issues that women's health providers are often better equipped to address. And so when pediatricians and women's health providers work together, they can also schedule postpartum and well women visits for new mothers at the same time as well baby and other visits for their children. So this can help improve adherence to postpartum visit appointments and more. The next population I'm going to talk about is addressing the often stigmatized needs of older women. So I have listed a couple of examples here on the slide, the first being heart disease, which is still regularly undetected in women, and primary care physicians and women's health physicians can work together to better address those needs. Additionally, complications during pregnancy like diabetes and preeclampsia are actually major warning signs for early heart disease in women. And so OBGYNs and other women's health providers have the opportunity to communicate those risks to women early on to it better impacts their health long term. And this can be especially important since those complications disproportionately affect women of color and add to disparities throughout the lifespan. The next example I would mention are fibroids. So 70% of white women and 80% of Black women have fibroids by the age of 50, and they're unaware of the symptoms or ignore those symptoms. This is an area where primary care providers can refer women to women's health providers and have those needs addressed. Additionally, we know that women are less and less likely to get cervical cancer screenings as they approach the age of 65. And so women's health providers and primary care providers can work together to ensure that older women are still getting those necessary cancer screenings. Next, primary care providers and women's health providers both are increasingly looking to address social needs and social determinants of health in their patients. And they also want to coordinate care with other physicians and social service providers. Some of those social needs might include housing and food insecurity, caregiving duties, intimate partner violence and other types of abuse, unemployment, substance use, and several more. The graph here on this slide shows that 91% of Medicaid managed care organizations reported in engaging activities to address social determinants of health. So the idea that I'm really putting out here is that as both public and private payers begin to design benefits that address social needs and social determinants, primary care providers will have the opportunity to become more engaged in addressing their patients' social needs as well. One example of this is these emerging alternative payment models. So alternative payment models give primary care providers and other providers the opportunity to coordinate care and address social needs by providing incentive payments, fixed extra funds, and other additional resources. So I'm sure one model that's very familiar to the listeners here is the patient-centered primary care medical home. And so both those accountable care organizations and pregnancy medical homes allow for improved care coordination. And so providers who are looking for more opportunities to address their patients' social needs can look to these models as a way to help them reach those goals and address those needs a bit better for women. And finally, I'm just going to take this opportunity, since we are really looking to focus on some of the disparities that women face in our healthcare system, to highlight some of the work that ACOG does through the Alliance for Innovation on Maternal Health, or AIM program. So AIM is a national alliance that promotes consistent and safe maternity care to reduce the instances of maternal mortality and severe morbidity, which you heard both Katie and Nancy talk about earlier. The AIM program includes several patient safety bundles that practices, hospitals, and health systems can implement, one of which is the reduction of peripartum, racial, ethnic, and disparities bundle. So primary care providers can also be aware of the hemorrhage, hypertension, postpartum basics, transition to well woman care, and mental health bundles. And all of those bundles have elements that could help you provide better care to postpartum women and their infants that you may see in your practices. And if you're interested in ensuring safe and equitable care, I recommend that you review those bundles and see what you can implement in your own practice. So that's kind of a bit of an action item for anyone who is looking for something they can do today. Overall, we want to say thank you, and we hope that this gave providers a clearer picture of women's unique health needs and how they can work to better address those needs within the healthcare system. As the system undergoes significant transformation, primary care providers can play a key role in ensuring that new payment and delivery models are designed to facilitate the health and well-being of all women. And we hope that you engage women's health providers as equal partners in this important effort. Thank you so much. I'm looking forward to answering questions, and I'll turn it back to Julie.
Great. Well, thanks to all of you. We have some questions coming in, and we are in a position where we have some time. I think I'll I'll just address some of the more administrative kind of questions coming from the group. Kathy and E. Willie asking that some of the citings for the data being shared be included, and then a request for sharing any validated tools, which could be something related to assessing implicit bias. I might be able to take that one back to my organization as well. But E. Willie also asked a really valid question that I actually had, I had a moment of thinking this myself, and we might as well put it out on the table. And the question is there a reason for a lack of diversity among the speakers? And also, I will add myself as a facilitator. While we are, all women, obviously, I made that note myself. I really appreciate the question being brought up. We don't have an answer for that except to say that we work with organizations who have broader diversity, and by nature of our roles, we were the ones who ended up, were passionate about this work and ended up being the speakers. But as always, these types of questions kind of add a level of intellectual honesty, and I very much appreciate that question. Katie, I think I'll ask a question of you. You gave us a lot of reasons why the voice of women should be heard. And I'm just wondering, for those of us, we have lots of different folks on the phone today. Some are delivering care, some are advocacy organizations, some are within the space of quality improvement. And I just wonder if you have any recommendations now that you've surfaced this information. How might our participants on the webinar react and take this back to their organizations? What might be some of the smart first steps to consider?
Yeah, that's a great question, Julie. Thank you. I think the first thing I would suggest is just becoming more aware of the research and the studies, and the news articles that flow by. When I started at the National Partnership, which is only a couple of years ago now, I wasn't even aware of the extent to which there are these challenges that women face. And since I have been here, there are really pretty regular articles, either in the academic press or the popular press, that highlight these issues. So I think just being aware that there do seem to be disparities, both between women and men, but particularly between women of color, and just being aware of it, and then doing a little bit of self-reflection and self-assessment. I think the tool that Nancy mentioned on implicit bias is a good one, and it's just kind of recognizing our own biases and behaviors, and then once we are aware of what we're doing ourselves, look for opportunities to correct. And then secondly, I guess I would say just consider the women with whom your practice or your work interacts as a real resource. So if you're a pediatrician asking the mom who's in with her kids vaccinating if there are other questions, or if there's a daughter bringing her mother in for a particular appointment, that there's just a really rich experience of how it feels to navigate the healthcare system and how it feels to be treated that way. Just to give you one tangible story, I was talking with a woman who started a blog called Mistreated, which tries to capture stories of misogyny in healthcare. And the story she told was she has, I believe, an autoimmune disorder, and had been having a series of ongoing challenges over the course of many years. Finally, her husband said to her, "You really have got to get this taken care of. You need to go in." And she said, "Okay, you have to come with me, though." And he said, "Why? That's ridiculous." And she said, "Because they won't take me seriously if you don't come." And so he kind of begrudgingly went. She went to her doctor, who was a woman provider, who said, "Why is your husband here?" And she said, "I didn't think you would take my concern seriously if my husband weren't here." And the woman provider said to her, "I'm glad you brought him. I had a woman in with the same symptoms you had last week, and I thought she was exaggerating, because surely if her symptoms were serious, her husband would be here." So it's just a tangible story that of like the way that bias creeps in. That's more explicit than I was anticipating when I started doing some of this work, but just to really reflect at what's shaping our views and our judgments on people as we interact with them throughout the day.
Thank you so much, Katie. Dr. Lee or Meredith, do you have anything to add on to what Katie articulated?
This is Nancy Lee. I have a really good review article on bias by Dr. Chapman and her colleagues in Wisconsin. And it has a description of the disvalidated implicit bias study, and I will get that reference to the organizers.
Great, thank you. And we have one of our participants, William, who indicated he actually answered the question in the chat, which I love. And his response of, in quality improvement, sometimes we call this, what can you do by next Tuesday, which will be tomorrow, so we'll give each other another week. William indicates, and I have to admit, I don't know if everybody can see the questions, but I will surface this. I think using the recording in a quality improvement team initiative with our providers and nursing leadership, as well as special diabetes, contract care, quality, and compliance, as well as administrative leadership. So it certainly starts to surface, surfacing more of an element of health diversity, but also cultural humility. William also asked a question around, if any of our panelists are aware of specific similar information that has been shared around Black women for Native American women. So I'll just open that up to the group. And again, if not, while we post this to the PCPCC website, I'll go back to my organization, Mathematica, and do a little research in this area as well, so we can add it to the resources. But any of you have any information that would help us understand opportunities related to Native American women?
I do not, but I do believe that this reference that I mentioned is an overall review, and it's a start. It's not specific to Native American women, but it's a start.
This is Katie. We did a survey in California called Listening to Mothers in California that specifically interviews and surveys women postpartum, and those analyses are cut by race, ethnicity, and I'm pretty sure, though I should probably double check, and I will double check when I stop talking and put you on mute, that we had specific analyses around Native American and Alaska Native, women for that study at least. And I just think in general, research around the experiences of women, then more narrowly women of color, and then more narrowly by race, and then more narrowly by ethnicity is just, there's just a dearth of information there. But I think it will be helpful, Julie, if you can help us dig some up, and let me see if I can confirm that our survey gets at that level.
That sounds great. And I think we have a lot of folks in the chat who want to do something by next Tuesday, asking for the citations, information on the research. Meredith, there was an ask that perhaps we could share the link to the resources, the AIM program that you mentioned. So we have lots of folks who are doers on this call, which does my heart good. So I think we'll post the presentation and the recording, but then hopefully working with the PCPCC team, we can add some references and resources. And I think we're almost surfacing an opportunity for an additional webinar on the subject to surface best practices based on the questions we're getting from the audience. So we have a question from Jennifer, and I'm going to just give it out to all of our panelists. And the question is, how can patients advocate for this awareness?
This is Katie. It's such a good question, an important one. I guess I would love to hear, I know this isn't how this is structured, but I would love to hear from the group, what is the best way for providers and practitioners for people to bring this to their attention. So, you know, what more could Serena Williams have done outside of standing in the middle of a hospital hallway in her hospital gown saying specifically what she needed? Like, how do we get, and as a policy advocate, I would really love to engage with this community to understand better kind of what are the systemic barriers, what are the ways that we can work together, because I think there are a bunch of different issues at play. I think one is that women are trying really hard to make themselves heard and just don't feel listened to. And at the same time, there are certainly structures in place that make it difficult to have time, to have the capacity, to build the trust, to do a lot of the things that would facilitate these conversations. So I'm not sure of the answer, but I would really love the input from providers and clinicians on this call. Also, just while I have the floor, just to say that we did look at breakdowns and listening to mothers, but we did not have sufficient numbers to do a breakdown by Native American, Alaska Native.
And I'll just surface. Oh, go ahead, Nancy.
Oh, no, I was just going to say this is so complicated. And, you know, every woman, frankly, has to take ownership of herself. And if she can do nothing else, she can do with that example you all talked about a while ago, where the woman took her husband and then told the provider why she took her husband. She told him the truth. She told her provider the truth, which is, you wouldn't listen to me if I didn't. And that's a start. And then I think for the organizations that are represented on this call, there are ways we all use to get input from our constituents. And how many of those do you have? And for example, surveys of the patient population and get real information on how they feel about their provider interactions. So that's one thing, or a couple of things.
And I'm going to surface a comment that Colleen made in the chat, that patients are not empowered by the healthcare system, and that's part of the problem. And I kudos to that comment. I think that's right. And a lot of this starts with all of you obviously are interested in having cultural humility, bringing health equity, valuing diverse opinions, and that's why you're on this call. And in many cases, just from the work I've done, my background's clinical and nursing, and I've also worked with a lot of different provider organizations and their quality improvement. And in that process, it really is about creating trust, and trust at the point of care. And without the leadership and having an expectation with an organization, many times that doesn't happen. And it's also through advocacy organizations, I think, helping consumers of healthcare in whatever, whoever they are, feeling the ability to ask the hard questions and have those conversations, and in some ways being, pushing the envelope even within the healthcare delivery system. So I think there's a little bit of opportunities at both sides, but it really comes down to creating a culture of trust. and not having judgment in terms of what's being heard. Lots of good resources. Thank you all for sharing resources you have on this. I'm not talking, so I'm going to look at the questions because I have a little more time. A good point that health coaches can bridge the gap. A lot of times, if you think about the work with promotoras, these are individuals who perhaps are patients who have a certain chronic disease that can be incredibly successful in a patient care setting, developing that relationship and the relationship of trust because they have experienced it. So I think it does get back to thinking about having patients in, an active way. CAPS is obviously a good survey, but truly an active way of garnering patient feedback from a variety of diverse perspectives in the process of delivering care. Many times this is used in the space of quality improvement, but it's also to help with, if there's interventions that either a practice or an organization wants to implement, having the patient voice. Many times when we had the patient voice, what happened is we were overcomplicating. Healthcare providers can, and I can say this because I have been one, can overcomplicate things, but just by having the patient voice, the folks who are experiencing your system can really help you with how to create a better system. No one goes to work every day in healthcare not wanting to provide good, quality, effective, evidence-based care that thinks about patients. But as Katie mentioned, it's sometimes there's a structure that makes the day get out of hand. Let's see. Looking at the questions, if anybody on staff, if you're seeing any questions that you want to raise while I'm reading, feel free to do so. I will read what Teresa writes. There is a need for female champions, particularly of color, that can advocate and educate providers and practitioners, as well as assessing providers, practitioners' implicit bias. Widespread use of tools developed. Caring is a partnership, and trust cannot be built if these individuals are not self-aware and work at eliminating the bias. Very well stated. And noted that doulas are a helpful bridge between women and families as well. So that's along the lines of a promotora model also. Well, I think we've rounded out some of the questions we can answer in the chat. I really appreciate, some of you have been very active in the chat, and I appreciate that. Some of the questions are a little logistical, so please know that while I may not have addressed your specific question about citing or resources that are available, we do have the log of the chat, and we'll bring that together and organize the information to be able to provide it back to all of you. So with that, I think we will end our webinar. I really thank the panelists for surfacing this to us. I thank all of you as participants for being so active in the dialogue and the questions. And I feel another webinar coming on. So we'll work with the PCPCC staff who are amazing. Allison and Chris are on the phone. And thank you again for your time. What a great way to start the beginning of a week with energy and enthusiasm. And please continue to take advantage of what PCPCC has to offer. And thank you so much.